Welcome to this edition of Access Together. These shows are made possible through the combined efforts of Shelby County Schools and GHS-TV. The shows are hosted by the members of the community and utilize the staff and facilities of Germantown High School. If you would like to watch our live stream or get more information about these shows, log on to our website, ghstv.org. Thank you, and we hope you enjoy the following presentation.
Hello and welcome to Living Well. I'm William Kinley. Today we're going to talk about magnetic resonance imaging, or MRI. An MRI is a non-invasive medical test that doctors use to diagnose and treat conditions. Dr. Paul Carruth, Chairman of the Department of Radiology for Methodist Le Bonheur Healthcare and Medical Director for the Radiology Department at Methodist Le Bonheur Germantown Hospital, joins us today to talk about this amazing technology. Welcome to Living Well.
Thank you for having me.
It's great for you to be here. Tell us a little bit about what you do. It's a good place to start.
All right. Well, I'm a diagnostic radiologist, which means I'm a medical doctor who is subspecialty trained in the acquisition, interpretation of medical imaging and performing image guided procedures.
That's quite a lot. What attracted you to this field?
Well, when I started medical school, I really had no inclination one way or the other about specialty. And frankly, I liked everything I got to do. And as a third-year student, you start to get into the hospital, get to start to see patients and see disease processes be worked up. And it seemed like whatever rotation I was on, we always ended up in the radiology department. And a lot of diagnoses seemed to be made there, and it seemed very satisfying to me. It's kind of a problem-solving subspecialty to be in. And so I started to take some electives and just fell in love with it.
One of the things I think sometimes people think is that radiologists sit in a dark room and read images and look at images all day. Tell us more of what your day is really like.
All right. If somebody wanted to stay in a dark room and just look at images, they could probably adapt their practice to that, but it's nearly impossible in today's age of medicine. I have a lot of patient contact. So although I do spend some time in front of a computer reading images, I'm also getting up, I'm going to consult with patients about their test, performing studies like fluoroscopy procedures where you have direct patient contact. And we also do a lot of image-guided diagnostic procedures like biopsies. So you're hands-on. So it's certainly not the sterile environment some people think.
That's wonderful. Well, that's one big change I would guess in the field. What are some other changes in radiology you've seen during your career?
Oh, it's amazing how we keep trying to keep up with technology. And as just the power of the computer has improved, it's improved the speed and accuracy of pre-existing technologies. An example for that would be CT, which was present when I started my training over 20 years ago, but it was very slow. It would take 30 minutes to do a CT scan of the head. Now we do that same scan with more images in about 5 seconds. So.
Wow.
That we keep trying to keep up with that technology and trying to make sure that we're using it appropriately.
From a patient's perspective, how do you think things have changed?
Well, we're able to see more non-invasively. So it helps us to be able to prevent some of the more invasive tests that we used to do. The exploratory surgery that you may have heard of that your grandparents had to go through, although sometimes happens today, is much less likely because we can do the non-invasive imaging to be able to try to figure things out beforehand. So when you do go to the operating room, it's for a procedure that's going to fix a problem, not diagnose a problem.
I see. That sounds like a big positive for a patient.
Absolutely.
So we want to talk about MRI technology. A good place to start is maybe a definition. What is an MRI, and can you compare it to maybe some of the other procedures that our viewers would be familiar with, like an X-ray or a CT scan?
Absolutely. It's interesting because the product of an MRI, or magnetic resonance imaging, is a cross-sectional image of the human body, which if you put it up next to say a CT scan image, they have some similarities because we are using sort of a slice approach to looking at the body. But the way it's acquired is entirely different technology. For a CAT scan or a regular x-ray, you're using ionizing radiation. And that's one of the reasons we try to be careful about when we x-ray patients, because there can be negative side effects with radiation. MRI has none of that. It's completely different technology that's based on magnetic fields. And as one of the brightest partners I ever had told me once, he said, it's basically magic. And we say that because the technology, the science behind it is so complex. But to delve into the shallow waters a little bit, we're 70% water. And every water atom is an oxygen and 2 hydrogen atoms in that molecule. And those 2 hydrogen molecules have a single proton. And those single protons have a magnetic field.
Right.
And by placing your 70% water body into that magnetic field, we can polarize your body basically. We make you a magnet. And then by using different pulses or radio frequencies, we change those magnetic fields and then listen for the signal that the body releases when it gets back into polarization. So like I said, it's magic.
Yeah.
And,
yeah.
But the images we get are just fantastic, and the density differences are based on how free that water is to move in that magnetic field.
I see. It is magic.
Yeah.
It's fascinating.
I'm glad I just interpret the images and don't have to understand the science behind them all
Well,
the
it
time.
sounds like you have a pretty good understanding of it. Well, walk us through a procedure.
Sure. So if your doctor says you've got a bad knee, you need to get an MRI of the knee, you would come to the radiology department or the outpatient center that has an MR. You would sit down with one of our technologists who is specially trained in the performance of MR, and they would screen you. Because as we're talking about a magnetic field, it's a very powerful magnetic field, and you can't go in with certain predispositions. So if you had a pacemaker, that would usually be a contraindication, although some of the manufacturers are now making MR-safe pacemakers. The majority are not. So once you get through that screening process, you go into the magnet. It takes about, depending on the study, 10 to 25 minutes to perform it, and then you're done.
Wow. Now I understand you have a new machine, a new magnet in your department. What's different with the newest technology?
Several changes with our prior magnet. First, we're excited because it's a second magnet for our hospital, so it's doubled our ability to do patients, so that helps everybody. But also, it's got a higher level of software, like we were talking about, computers, increasing our ability to do work. The software that comes with the magnet allows us additional abilities to post-process our data, also allows us to acquire different images we haven't done before. It has greater field strength or greater gradient strength, which means we get better signal from the magnet. And we also it has something called embedded coils, which doesn't mean a lot to you or I or the patient, but for the technologists, it speeds the acquisition up because they don't have to add additional coils to the machine as they're doing the studies.
Well, speed is kind of a big deal I've had the procedure before, and I know others that have talked about it. They worry about it being in the tube and it being claustrophobic and tight. So speed is one thing if you can be done quicker. Are there other attributes of the new system that make it better for those patients?
You mentioned one of the most important ones that I didn't mention. It was the fact that it is a more open magnet than what we previously had. Not being open that you can look side to side and see the walls, but the aperture or the hole is bigger. It's the biggest one that's available on the market. And also the length of the magnet is shorter. So although it's not a fully open magnet, it is a more open magnet.
I see. That sounds like a big positive if you have those words.
Oh, absolutely. It means more people can tolerate the study.
That's wonderful. It's time for a quick break. Up next, we'll talk about how an MRI can help cardiac patients and also its neuro capabilities. Please stay with us.
Welcome to Germantown High School, an international baccalaureate creative and performing arts optional school, a destination school for students who are going places.
Our students are of the highest caliber when it comes to their academics and knowledge.
The IB program is a very rigorous program.
You were challenged in a way that you thought you couldn't be challenged you succeeded, something that other kids may not have thought they could do.
They're accepted to colleges that are just, dream colleges for so many people.
Germantown High School offers a CAPA program, the Creative and Performing Arts program.
When I first came here, I saw the television studio and I was just amazed at what all I saw.
Kids do everything, that they're taught every detail that has to do with theater arts and creative arts.
I love a lot of things about Germantown High School, but primarily what I love is the athletics. There's something exciting around every single corner.
We probably are one of the most diverse high schools in the state of Tennessee, maybe the United States.
I would never doubt about sending your child to Germantown High School.
This high school is something not like any other high school that we have.
There's definitely fun in the work. We find fun in everything we do.
You're watching the award-winning GHS-TV, a nationally recognized student television station.
Welcome back. We're talking with Dr. Paul Carruth, Chairman of the Department of Radiology for Methodist Le Bonheur Healthcare, and also Medical Director for the Radiology Department at Methodist Le Bonheur Germantown Hospital. Dr. Carruth, when it comes to cardiac imaging, is there a role for MRI?
There is. That role is expanding. We already have a lot of good techniques for cardiac imaging. So we don't want to just add another layer of workup or technology onto what we're doing. We hope to be able to improve or replace pre-existing technology. For example, echocardiography is a fantastic study that's non-invasive to look at cardiac function. But not everybody has a very good anatomic window to look at the heart that way. And that's where MR could be another alternative, where we can look at the heart both anatomically to make sure the chambers are of normal size, that there's no anomalies, congenital anomalies, but also look at cardiac function and be able to actually see the motion of the cardiac muscle and to evaluate what's called the ejection fraction, or how much blood is ejected each time the heart beats. So that's one. Another area that I think is going to be expanding more is to look at the muscle to see if it's viable or not. And the reason that's important is if somebody has a heart attack and they lose part of that heart muscle, the decision is, do you do surgery to try to reperfuse or increase the blood flow to that area? And you need to know if there is viable heart tissue there to save. And that's something that can be a challenge with some of our nuclear medicine studies, as well as cardiac catheterization procedures. So contrast enhanced MR of the heart will be a way that we can try to augment that workup to look to see if there is enhancement or blood flow to the cardiac muscle.
Is this a common type of testing, or is it pretty leading edge for our community? It's
pretty leading edge for our community. A lot of times when new technology comes in, it will be adopted quickly depending on its success. And I suspect this will be very successful.
You mentioned some things that cardiac imaging will show. Are there more with the patients, and kind of what type of patient? If you came, the typical one that comes to mind, if you came into the emergency department with chest pain.
Right. With MR, there's a little bit of limitation with coronary imaging, which is with the acute coronary syndrome patient is where you're most looking at that. So still the cardiac catheterization, SPECT heart studies, CT angiography probably still have the first line role in that.
Okay.
I think another area where MR is going to be helpful is some of the more complicated cardiomyopathy cases where somebody has sick heart that's not working well and other studies haven't figured out why that is. And we can look for some of the infiltrative cardiomyopathies that it could be hard to see with or diagnose without a tissue diagnosis. MR being able to help with those cases.
I see. Let's switch gears a little bit. I think we've all heard a lot about MRI, probably first from sports injuries, that such and such athlete is going to get an MRI to see. How is MRI used in musculoskeletal imaging?
It's a great tool for musculoskeletal, and that's where the intrinsic anatomy of joints is shown really well with MR. Better than with CT or with plain film. With MR, you're seeing all of the soft tissue, all the bones, tendons, ligaments that you can't see with other modalities. So it's again, non-invasive. If somebody has a very specific injury that the orthopedist is suspected on physical exam, they can confirm that with an MR before they have to plan for surgical versus non-surgical treatment. So it's great for musculoskeletal imaging. We do a lot of just plain what we call dry imaging of joints, but if necessary, we can also do contrasted arthrography of joints where we inject contrast into the joint before we do the MR. It can really help with some of the more subtle injuries, and a lot of the ones that you hear on ESPN, a labral tear, for example. It's very difficult to diagnose a labral tear without a contrasted MRI of the shoulder, without going to have an arthroscopy.
I see. Well, it is fascinating. I'm sure the images are amazing to look at.
It's incredible. I mean, it's almost like being in surgery how well you see the anatomy.
So if you step back in time before your time, how would that diagnosis have been made?
Well, we used to do just routine plain film arthrography. So you would come in with a sore shoulder, we would inject routine iodinated contrast into the joint, do 3 different views of the shoulder after we exercise you for 10 minutes. And basically we could tell you, do you have a rotator cuff tear that's complete? And that was about it.
Okay.
The much more subtle findings that we have now, you had no chance to see on an x-ray.
That's a great step forward.
It's incredible.
How about neuroimaging?
Neuro is really where MRI first took off. It's fantastic for looking at the brain and the spinal canal. Again, the detail is better than with CT. It's not as quick and accessible as CT always is. So if you were to come into the ER with a head injury, still the frontline imaging that you would get would be a CT of the head. But for everything else, MR is vastly superior from a resolution aspect, so we can diagnose stroke earlier on MR. It's very sensitive for hemorrhage. For brain tumor evaluation, there's no other option other than MR, particularly contrasted MR, where we give IV contrast to look for areas of abnormal enhancement of the brain.
You mentioned stroke. I know the area that we live in is, we're several belts, but one of our belts is we're the stroke belt. We live in the stroke belt. How do you work in with that diagnosis? I know there's probably a significant number of patients that come in to rule out a stroke.
Right, and typically as soon as they hit the emergency room door, we're going to do a CT, because that's the quick way to rule out a hemorrhage in the brain, which is treated completely different than if somebody has an ischemic stroke, which is what we typically think of, where blood supply has been blocked to the brain. Usually shortly after that, MR is incorporated into the workup because it is so sensitive for early changes of ischemia of the brain. And sometimes we can catch changes so early that treatment can be initiated before there's permanent damage.
And moving on with that treatment, do you or partners of yours go on with that treatment? How does that work?
Oh, right. If you're in an early enough window, you can be given clot-busting medication just through a peripheral vein, and you can see immediate improvement within minutes. If it's a little bit farther along, then we have specialists, either a neurointerventional radiologist or an interventional neurosurgeon, who can do catheter-directed thrombolytic therapy, where you take a catheter up into the vessels, actually into the head, and find the vessel that's blocked and directly use the anticoagulants or the thrombolytic agents.
It's just amazing.
Yeah.
Thank you. Still to come, abdominal imaging is a growing field. We'll learn more after this quick break.
Most party fouls are pretty dumb. But if you decide to drink and drive underage, you could lose your license and your freedom. Underage drinking and driving. The ultimate party foul.
Okay, so we drowned the fire, stirred it, drowned it again, and now just feel if it's cold.
Yeah.
Cool.
Smokey just gave me a bear hug.
I know. Already posted it.
You're watching the award-winning GHS-TV, a nationally recognized student television station.
Welcome back. Dr. Paul Carruth, Chairman of the Department of Radiology for Methodist Le Bonheur Healthcare and Medical Director for the Radiology Department at Methodist Le Bonheur Germantown Hospital, is here with lots of interesting information about MRI. Dr. Carruth, let's talk about abdominal imaging now. Is that a growing part of your field?
For MRI, it's really been expanding a lot. We've always done a lot of abdominal imaging, but it's been predominantly with CT or plain film. And one of the limitations in the past with MR has been motion. And even though you don't think that much that when you're lying still that your abdomen's moving, but every time you take a breath, there's movement of the liver, the spleen, and the other organs. So with our new magnet and with some of the newer software, we've been able to shorten our image sequences to really reduce image artifact, and it's allowed us to do more workups for abdominal pathology, particularly solid organs such as the liver, kidneys. We work up masses to be able to better characterize, and sometimes we can determine benign versus malignant just based on imaging characteristics.
Okay.
Also, we're able to see a little bit more of the hollow organs or the intestines better now with the faster sequences. So in some of the inflammatory bowel diseases like Crohn's disease, we're starting to do a little bit more MR. And the thought there is you have somebody with a chronic illness who's going to have multiple imaging studies. If you can reduce radiation exposure by using MR, that's an added advantage.
You know, you've opened the window in talking about bowel imaging. I think our viewers would wonder, is this a technology that can replace screening colonoscopy and the great joy we have with that?
I'm afraid not. And as a 49-year-old about to turn 50, I wish I could say it is. But I'll be having my screening colonoscopy next month. So I would not tell anybody not to get their screening colonoscopy. It's absolutely vital. We are working with CT to try to do more screening of the colon with CT.
Okay.
But we're still not to the point that I think that we can avoid our colonoscopies yet.
And as I understand, even if you did, you don't avoid the lead-in, the prep for the procedure.
The prep is used no matter what imaging modality you do. Just like a barium enema, you have the same prep for that as you would for your colonoscopy.
Just good information to know.
That's right.
How about imaging of the pelvis? How is that expanded with this technology?
It has really helped us with evaluating patients who had abnormal ultrasounds, which is kind of the gold standard for pelvic imaging. It's really helped some of my partners who do uterine fibroid embolizations, which is something we see a lot in this area, or uterine fibroids, which can be a cause for dysfunctional uterine bleeding. And in the past, the only treatment was really hysterectomy. So it's added and another option for women to have embolization procedures where we, through a catheter, go in and inject medicine to actually, rather than opening up blood flow, blocking blood flow to these fibroid tumors of the uterus, and, and can reduce or eliminate their dysfunctional bleeding. And MR is used in that as both a preoperative and a postoperative evaluation to see, is the patient a candidate first of all, and then after the procedure, how successful was it? And it's much more sensitive and specific than pelvic ultrasound.
That sounds, the story you share is an interesting one with all the focus in healthcare to provide greater value. I would assume not having an open procedure, a surgical procedure, would recovery time be less also?
Oh, it's a same-day surgery procedure. So they come in at 7 o'clock in the morning and they're usually gone by 2 in the afternoon.
That's wonderful.
Yeah.
That is wonderful. Can you talk a little bit about the team that you work with? We've mentioned a lot about the machine, but I know it's much more than that.
Yeah, that's near and dear to my heart. The technology is fantastic, but the reason I love working where I work is because of the people I work with. We have a fantastic set of MRI technologists who have gone that extra step to train for that modality, and they run that machine very well, but they're not just button pushers. They are patient caregivers, they're patient advocates. They, as you can understand, it's a stressful situation most people are in when they come to get an imaging study. And MR is pretty stressful just from
it's a little intimidating.
That intimidating machine. They hold hands, they give kind words, they walk people through. They are the best sedative that anybody could ever have. And they really advocate for their patients. They want to make sure they get the best care. And that's something that's not unique to MR. Our whole department is that way, as is the health system.
Sure, sure. Well, that's a wonderful testament. Do your technologists work in multiple areas, or are they focused in an area?
They're focused. Most, if not all, technologists are subspecialized these days. Do we have a few that can cross-train into other areas? That's available if we need it, but no, an MRI tech is going to do MRI 100% of the time, as our interventional technologists and our CT technologists and ultrasound. They are all subspecialized and they do a fantastic job.
I see. Well, what does the future look like in MRI, but really in medical imaging overall? What's next?
I wish I had that crystal ball, because it's hard to say. Like we keep trying to keep up with advances in technology, but we have to keep an overview that we're not just running machines, that we're taking care of patients, that we're using the technology we have appropriately, so that we're not just spending money ordering tests, that we're doing the appropriate test in the appropriate situation. I think this current technologies that we have will continue to advance and get quicker and better imaging, particularly in MR. I think in some of the nuclear medicine studies that we do, we're going to start being more specific with molecular level agents that we can administer and then image, particularly in oncologic imaging or cancer imaging.
Okay.
So I think we're going to see advances there. MR, as we shorten the sequence times and as the magnet strengths increase, we'll just continue to be able to have more capability there.
Well, it's pretty impressive, all the things that you've shared.
It's a fun job to have. I'm happy to go to work every morning.
Well, it sounds that way, and I'm sure that's a big contributor to why you're so wonderful at what you do.
Oh, I appreciate it.
That wraps up our show for today. For more information on this show and other GHS-TV shows, please visit ghstv.org, where you can watch live streaming 24 hours a day. You can also check us out on GHS-TV on Facebook and Twitter. I hope that living well will help you and your family lead healthy lives. Thanks for watching. I'll see you next time.